We continue our module 2 with a focus on family planning and population policies of India as lecture 8. Family planning means choosing if, when, or how many children to have. It includes information, counseling, and access to safe methods. Condoms, pills, and IODs, implants, and sterilization. Good family planning helps space pregnancies, which lowers maternal and infant deaths. It also reduces unsafe abortions by preventing unintended pregnancies. When families can plan, parents can invest more in each child's health, food, and schooling. Women gain time and control over education, work, and rest. This strengthens gender equality. Men are part of the solution. Shared decisions and male methods matter. Teens need accurate, age appropriate sex education and confidential services to avoid myths and risks. Services must protect privacy, be affordable, and reach rural, urban, migrant, and disabled people. Family planning is about rights and health, not forcing targets or quotas. It supports wider goals poverty, education, women's empowerment, and economic mobility. So, treat family planning as holistic development, combine healthcare, education, and social support, not just a population policy. India's family planning policies emerged against the backdrop of rapid population growth. In the 1950s, fertility rates were very high, creating fears of food insecurity and economic stagnation. Today, fertility has declined nationally, but states like Bihar and Uttar Pradesh still record higher rates. India faces both the challenge of population momentum and the opportunity of a democratic dividend, where a young workforce can fuel growth if policies are aligned. In the post independent era, India's leaders recognized that unchecked population growth could undermine development. Concern about food shortages, unemployment, and poverty drove the conversation. International agencies like the UN and USAID also encourage family planning initiatives. By the first 5 year plan, population was officially noted as a barrier to national progress. This set the stage for the world's first national family planning program. In 1952, India became the first country in the world to formally adopt a national family planning program. The approach was cautious, beginning with urban clinics offering contraceptives and education. Methods like condoms and diaphragms were promoted, but uptake was modest. Importantly, the program had limited reach beyond cities, reflecting early challenges in engaging rural populations where the majority of Indians lived. In the 1960s, India scaled up family planning under the 5 year plans. Hundreds of clinics opened, and the program focused on medical services run by doctors and hospitals. International donors supplied money, supplies, and trainings. The approach assumed if clinics and methods existed, people would automatically use them. But many rural families faced distance, cost, and mistrust of government health posts. Programs rarely listed to local beliefs, gender norms, or the role of mother in law and husbands in decisions. Services were often top down and rushed, with little counseling or follow up. Women worried about side effects, while men feared stigma around vasectomy. Health workers had targets, which sometimes led to poor quality and weak consent. Because the social reasons of large families, farm labor, child survival, old age security were not addressed, demand stayed low. Urban educated groups adopted contraception faster, but rural high fertility areas saw limited change. and that was the place where change was mostly wanted. Result was big spending in many clinics but modest fertility decline where it mattered the most, showing the need to link family planning with community engagement, livelihoods, and respectful care. The emergency period marked a dark chapter in India's family planning history. Sterilization drives intensified and targets were strictly enforced, leading to abuses, especially among the poor and the marginalized vulnerable communities. Male sterilization was promoted aggressively, leading to fear and resistance. This period left a lasting stigma on family planning with public distrust that continues to echo today also. After the backlash of emergency, the government shifted towards a voluntary approach. Policies emphasized informed choice and dignity, seeking to rebuild trust with the public. The focus shifted from sterilization to spacing methods like IUDs and pills. Community health workers began playing a larger role in promoting family planning. This marked a slow transition from coercive to right based approaches. Now, in the 1980s to 90s, family planning still ran on numeric targets. Health workers were told to deliver a fixed number of sterilizations each month. Meeting quotas mattered more than good counseling or client choice. Most procedures were tubectomies, so the burden fell mainly on women. Men's participation stayed low, and vasectomy was rarely promoted. Camps were sometimes rushed with crowding, poor privacy, and weak follow up. Consent was inconsistent. Many clients did not hear about side effects or other methods. Quality problems were there, infection control, pain management, transport, and aftercare. These things were all common. Feminist scholars said this system treated women as numbers, not as people or human beings with rights and plans. They argued for choice-based approach, pills, IODs, condoms, injectables, spacing advice, and respectful care. They also called for client rights, characters, grievance systems, and data on quality, not just counts. The lesson targets without rights create inequity and poor care. Programs must center on informed choice, safety, and dignity. The 1990s brought a shift to the reproductive and child health approach. Family planning was no longer a standalone, target driven program, it was integrated with maternal and child health. The focus moved from counting procedures to meeting client needs and improving quality of care. Reproductive and child health treated as a life cycle issue from adolescent to menopause. Contraception was linked to safe pregnancy, delivery, postpartum care, and newborn health. Services added counseling, informed choice, and screening for sexually transmitted infections and reproductive tract infections. Planning was decentralized, so district could design services for local realities. Health workers were trained for respectful care, privacy, and follow ups, not just to follow the numbers. The package also emphasized immunization, nutrition, anemia control, and breastfeeding support. Data systems began to track quality indicators like stockouts, complication, counseling time, not only total numbers. Community participation was the prime focus. Women's groups, panchayats, and NGOs helped reach underserved areas. Overall, RCH reframed services as right based, client centered care that keeps women and children healthy while supporting informed family planning choices. The National Population Policy 2000 marked a turning point in India's demographic vision. It set the ambitious goal of achieving replacement level fertility by 2010, linking population stabilization with broader development outcomes. The policy emphasized universal access to contraception and reproductive health services, ensuring that couples could exercise informed choice. A major innovation was the integration of family planning with maternal and child health goals, thereby reducing infant mortality rate and maternal mortality ratio. Unlike earlier policies, NPP 2000 explicitly adopted a voluntary, right based approach, moving away from coercion. It also recognized the importance of addressing socio demographic determinants such as education, poverty reduction, and women's empowerment. The policy still continues to influence India's reproductive health strategies today. The National Population Policy 2000 aimed to meet India's very different needs across states and districts. First, it focused on easy access to contraception in every village and urban slum. It expanded the method mix: condoms, pills, IUD, injectable, implants, and safe sterilization so people could choose whatever they liked or whatever suited them. It promoted later age at marriage and delaying the first birth because spacing lowers health risks for mothers and babies. The policy linked family planning with maternal and child health, vaccine, and nutrition services. A big push was to strengthen primary healthcare centers, sub centers, and outreach so rural and tribal areas were not left out. NPP 2000 stressed quality of care, respectful counseling, informed choice, privacy, and follow up. It saw women's empowerment as a core: literacy, skills, jobs, and control over income improve health decisions. Adolescents were included through life skills and reproductive health education and youth friendly clinics. The policy encouraged multi sector partnerships, NGO, private providers, panchayats, and community groups to widen their reach. It set time bound goals to reduce infant mortality rate, maternal mortality ratio, increase couple protection rates, and asked states to make decentralized plans. Overall, National Population Policy 2000 reframed family planning as a shared developmental responsibility that advances health, rights, and opportunity and not just a government target. This policy helped lowered fertility in many states, moving closer to the replacement level. People got easier access to contraception in clinics, outreach camps, and through ashas, of course. The method mix improved. More use of condoms, pills, IUDs, and injectables, not only sterilization. Family planning was linked with RCH and later with NRHM, NHM, that is National Health Mission and National Rural Health Mission, so services reached villages more regularly. Supply chains, training, and supervision became stronger, reducing stockouts and poor quality. Public campaigns made family planning feel like a responsible, normal choice for couples. More couples practiced spacing, which reduced unintended pregnancies and unsafe abortions. Better spacing and better antenatal care helped lower maternal and infant deaths in many districts. Adolescent programs began offering life skill and counseling, bringing youth into the conversation. Data systems started tracking quality and coverage, not just procedure counts. Civil society and private providers joined delivery, widening reach to hard to serve groups. Progress was uneven across regions, but the overall trend showed National Population Policy 2000 shaped India's population and health outcomes in a positive way. Despite progress, this policy faced persistent challenges that remain relevant even today. Regional disparities meant that states like Bihar, Madhya Pradesh, Rajasthan, and Uttar Pradesh lagged behind in fertility decline. A significant unmet need for contraception continues, especially in rural and marginalized communities. Male involvement in family planning remains very low, with vasectomy uptake negligible compared to female sterilization. Cultural, social, and religious resistance further limits family planning adoption in many areas. In addition, underfunding and weak health system capacity constrain the ability to provide quality and equitable services. These challenges highlight the structural inequalities in health landscape and call for more innovation, context specific approaches. Implementing family planning methods brings advantages. Healthier mothers and healthier babies, fewer high risk pregnancies, more years of education, more years of work for women, and better use of family income. It also lowers maternal and infant deaths by helping couples plan, delay, and space births safely. Within family planning, spacing methods are a key. Condoms protect against pregnancy and STIs like HIV, and they are cheap and work best when used every time and correctly. Oral contraceptive pills are very effective and reversible. User just needs clear advice on daily timing and what to do if a pill is missed and what small side effects the person can have and how can the person cope with them. Intrauterine devices like copper T or hormonal devices give long acting reversible protection for several years and suit people who want reliable spacing without daily action. Injectables provide 1 to 3 months of protection per dose. Reminders and easy return visits improve continuation. Implants for 3 to 5 years are a highly effective form of contraception and can be removed anytime to return the fertility of the person. Emergency contraception is a backup after unprotected sex or method failure. It does not replace regular methods. Every method has its pros and cons, its effectiveness, its side effects, then cost, privacy. So, informed choice and good counseling matters. Services should ensure consistent supply, respectful care, and follow up so people can switch methods if they need. Expanding the access to spacing methods reduces unintended pregnancies and unsafe abortions, improves birth spacing, and ultimately lowers maternal and infant mortality while strengthening the family well being as a whole. Permanent methods remain the backbone of the India's family planning program, especially family sterilization. Sorry. Permanent methods remain the backbone of the India's family planning program, especially female sterilization, which accounts for the majority of contraceptive use. Male sterilization, though safer and simpler, is underutilized due to social stigma and misconceptions. Both methods are voluntary and considered irreversible, requiring thorough counseling and informed consent. Quality of care during sterilization procedures is vital to ensure safety and maintain public trust. While these methods provide effective and lifelong protection, over reliance on female sterilization reflects gender imbalance in reproductive responsibility. Promoting male involvement and balancing the contraceptive method mix is crucial to achieve equity and sustainability in family planning programs. The recent expansion of India's contraceptive basket represents a significant policy shift. The inclusion of injectables and implants offer women longer term, and more convenient options. Centromin, a non hormonal pill developed in India, provides an alternative for those who cannot use hormonal methods. A wide range of methods enhance couples' ability to choose what best suits their needs. This diversification reduces discontinuation rates and unintended pregnancies. It also reflects respect for diversity in reproductive health needs, recognizing that one size does not fit all. Expanding method choice is central to strengthening right based family planning programs, ensuring both effectiveness and client satisfaction. Ashas and community health workers are the front line for family planning in villages. They give one to one counseling in local language, explaining each method and who it suits. They dispel myths. For example, the IOD causes infertility or pills cause permanent harm. By door to door delivery of condoms, pills, and ECPs, they make methods easy to start and continue. They keep reminder lists for refills, return date for injectables, and IOD follow ups. When needed, they escort clients to health centers for IOD insertions, implants, and sterilization. They also check warning signs, encourage postpartum spacing, and link clients to doctors. Because they are from the same community, they build trust with families and husbands. They work with women's groups and panchayats to normalize spacing and shared decision making. Incentives support their work, but they need regular training, supplies, and supportive supervision. Logistics matters. Ashas require steady stocks, job aids, and clear referral lines to higher centers. Strengthening Ashas improves uptake, continuation, and informed choice, making family planning more equitable for rural and hard to reach households. Male participation in family planning is one of the most under addressed areas in India's population policies. Condom use remains limited, while vasectomy continues to be stigmatized and rare. Engaging men in family planning counseling sessions can improve acceptance and shared responsibility. Programs must actively challenge gender stereotypes that assign reproductive responsibilities solely to women, creating supportive environments including positive media portrayals and community role models can normalize male involvement. Increasing male participation improves family planning outcomes, reduces gender inequities, and strengthens family health overall. Without men's active role in family planning, these programs will remain incomplete and disproportionately keep burdening the women. Adolescents need special reproductive health support because their bodies and lives are changing fast. Early marriage and pressure to prove fertility push many girls into early risk pregnancies. Many teens do not know how contraceptives work or where to get it safely and privately. Comprehensive sexuality education in schools teaches consent, bodies, relationships, and method use. Adolescent friendly clinics must guarantee privacy, non judgmental staff, and convenient hours so young people actually come. Services should include menstrual health, anemia screening, sexually transmitted infections testing, and treatment and counseling on delay of first sex marriage and first birth. Access to condoms, pills, and emergency contraception should be easy. With clear guidance to avoid misuse, programs must involve boys and men, not only girls, to challenge harmful norms and share responsibility. Community outreach should work with parents, teachers, ashas, and panchayats to reduce the stigma and support the teens. Keeping girls in school and offering life skills and vocational options strongly lowers early marriages and fertility. Digital tools can give confidential information and referrals, especially in remote areas. Investing in adolescents now improves health, education, and earnings, speeds fertility decline, and helps India meet SDG goals for gender equality and health. Urban rural gaps in family planning are big and stubborn. Cities usually have clinics, pharmacies, and trained staff. Village may have none nearby. Even when a rural subcenter exists, it can run out of supplies or lack a provider on duty. Bad roads, long distances, and costly travel make a quick clinic visit an all day affair. Privacy is another hurdle. Urban slums face different barriers, crowding, unstable housing, irregular work hours, so people can't keep appointments. Language and trust matter too. Migrants in cities may know where to go, but they don't go for the fear of poor treatment, inequality showed to them, and their language barriers. Method mix is uneven. Rural areas often rely mostly on sterilization, while cities have better access to spacing methods like pills, condoms, IUDs, and injectables. Follow up for side effects is weak in rural areas, so women stop using methods after the first problem. Data systems also miss the poorest, both in remote hamlets and informal settings. So, planning overall overlooks them. What helps? Mobile health units, fixed day outreach camps, and community distribution through ASHAs with steady resupply. Urban slums need evening clinic hours, peer educators, and door to door counseling in local languages. Telehealth, e-voucher schemes, and task sharing to nurses, A&Ms can shrink distance and cost barriers. Decentralized planning with budgets controlled locally and targets set by the community need makes services responsive and brings us closer to true equity. Socio-cultural barriers are some of the hardest to change because they are laid to identity, honor, and tradition. Socio-cultural barriers are some of the hardest to change because they are tied to identity, honor, and tradition. In many families, having many children, especially sons, is seen as a security and status, so contraception feels against culture. Religious teachings are sometimes interpreted as banning modern methods. Rumors spread fast. People fear that pills cause infertilities. Decisions about sex and childbearing are often made by men or by elders, limiting a woman's say. Talking about sex is a taboo, so couples, especially adolescents and newlyweds, avoid these topics and keep silence to keep their respect. Low literacy and language barriers make it hard to understand method instructions, side effects, and follow up care. Gender norms label contraception as a women's responsibility, so men do not use condoms or consider about vasectomy. These barriers vary by caste, tribe, region, so one message does not fill all communities. What helps? Respectful, culturally sensitive counseling, clear myth busting with visuals, and confidential youth friendly spaces. Engaging religious and community leaders, involving men and mother in law, and using local media and peer educators builds trust. Empowering women through self help groups, cash transfers for girls' schooling, and legal support increases their bargaining power at home. When families see the spacing, births improves the mother's health, the child growth, and the household budget, acceptance of family planning grows. When families see that spacing births improves the mother's health, improves the household budget, improves the child's growth, the acceptance of family planning methods grows. Gender norms shape who decides, who uses, and who pays for family planning in India. Women can still carry most of the load. Men's participation is low. Inside many households, elders or husbands make reproductive decisions, so women may not be able to have their say or to start or switch or stop a method when they want. When a woman has more schooling, income of their own, and mobility, they negotiate better. Programs that invite couples together improve shared decision making and method continuation. For male focused outreach, peer educators, workplace sessions, and respectful counseling in clinics can normalize condoms and vasectomy as responsible choices. Mass media and community leaders can challenge stereotypes. Provider bias also matters. Training staff to offer the full method mix without pressurizing women helps spread responsibility more fairly. Cash or non cash incentives that include men can shift behavior. The private sector and NGOs play an important complementary role in family planning in India. Private clinics and pharmacies expand contraceptive access, especially for urban and peri-urban residents who may prefer anonymity. Many NGOs introduce innovative service delivery models that later influence government programs. They also contribute to demand generation through their campaigns. Partnerships between government, private, and civil society actors enhance outreach and efficiency. Strengthening collaboration and accountability between these sectors is very essential for scaling the family planning services equitably. Information, education, and communication campaigns have been central to India's family planning efforts. Folk media, local platforms such as street plays have been effective in many communities. To reinforce this small family norm in recent years, digital platforms and social media campaigns have targeted younger audiences and tailored messages. These campaigns not only spread awareness but also contract myths and misconceptions. Sustained, culturally appropriate messaging continues to be critical for increasing acceptance and normalizing family planning practices. Family planning and maternal child health are deeply linked. When people can plan pregnancies, fewer mothers face dangers, unintended births. It also reduces the need for unsafe abortions by spacing pregnancies. Children who are not born too soon after a sibling tend to grow better and do well in school. Avoiding high risk pregnancies, such as very young mothers, very old mothers, or many closely spaced births, protects entire families. Integrating family planning with antenatal care and child health services saves times for families and makes health system more efficient. Men's involvement support spacing, condom use, and shared decisions. When government ensures a full range of safe, affordable methods and respectful counseling, maternal and infant mortality fall. Family planning supports many sustainable development goals at the same time. Family planning supports many sustainable development goals at the same time. It directly advances SDG 3, that is good health. It helps SDG 1, that is no poverty. Then we have SDG 2, zero hunger, and SDG 4, quality education. When women can choose if and when to have children, they gain power over their lives. Access to contraception lets women and access to contraception lets women and girls stay in school longer and enter paid work. Smaller, well planned families reduce pressure on housing, water, and local services by easing demand on natural resources. Partnerships among government, NGOs, and communities to deliver family planning reflect SDG 17, that is, Partnerships for Goals. In short, making contraception available, affordable, and dignified is not only a good health policy, it is very important for achievement of sustainable development goals. Recent innovations in digital health are transforming family planning delivery in India. Mobile health applications provide counseling tools and resources directly to users, improving accessibility. SMS reminders, telemedicine, youth friendly digital platforms. These innovations complement traditional outreach methods and help overcome barriers. Looking ahead, future family planning policies must build on past lessons while addressing current gaps. Increased male engagement is critical for balancing responsibility and reducing gender bias. Underserved and high fertility states must be prioritized with tailored strategies and resources. Integrating family planning with maternal, child, and adolescent health initiatives will maximize synergies. These directions will help India sustain its progress towards population stabilization and equitable health outcomes. In conclusion, family planning has been centered to India's development journey. Policies have evolved from coercive and target driven approaches to voluntary, right based frameworks that respect individuals' choice. While significant achievements have been made, including declining fertility rates and expanded contraceptive access, challenges such as disparities, socio-cultural barriers, and low male participation persist. The way forward requires a stronger focus on equity, innovation, and gender balance. Family planning is not just a health intervention, but a pathway for healthier families, empowered women, and a stronger nation. Its continued prioritization will determine India's progress towards sustainable development. Thank you.